This video will describe how colorectal cancer outcome can be predicted from routine diagnostic sections using deep learning. The marker was developed by training and tuning machine learning algorithms using 4 cohorts. These include patients from the Victor trial in the UK, a consecutive series of patients treated in Gloucestershire and included in the Gloucester colorectal cancer study in the UK, and consecutive series of patients treated in Norway at Aker University Hospital and Akershus University Hospital. The patients had early-stage colorectal cancer, stage 2 and 3 in the Victor trial, while also stage 1 in the other cohorts. Surgery was performed between 1988 and 2004. The patient slides were prepared in Cheltenham, Oxford and Oslo, and scanned using both an Aperio AT2 scanner and a NanoZoomer XR scanner. The whole slide images were sorted into training and tuning cohorts. Images from patients with distinctly good or poor disease outcome were used for training 10 deep learning networks, while images from the other patients were used for tuning to determine the final classifier. This classifier of patient outcome was termed the DoMore V1 CRC marker. We begin with the scanned conventional haematoxylin and eosin stained section. First, the tumor region is delineated with a deep learning segmentation network. This image contains an order of 100,000 by 100,000 pixels. These dimensions are larger than is currently feasible for classification by deep learning methods. It is digitally resized to a size corresponding to a maximum dimension of 1600 pixels. The red, green and blue channel of the whole slide image are then stacked as grayscale images. Convolutions and spatial pooling are then applied to the stack, generating 64 new representations. A second sequence of convolutions and spatial pooling generates 128 new representations. A third sequence of convolutions and spatial pooling generates 256 new representations. This cycle of convolutions and spatial pooling is repeated. Finally, the representations are rescaled to the original size with a learned upsampling, before a pixel-wise softmax is applied. This results in a probability map, highlighting regions with tumor. The probability map is then segmented, resulting in the final mask. As mentioned earlier, the whole slide image dimensions are larger than is currently feasible for classification by deep learning methods. To preserve prognostic information contained at high resolution, the tumor region is partitioned into multiple non-overlapping image regions, called tiles, at 10x and 40x resolutions. For this demonstration, we begin with the 40x tiles. All 40x tiles are processed individually by a convolutional neural network. Here we see the first tile being processed. This network consists of a representation network and a pooling function. After all tile representations are computed, the pooling function collects all tile representations and performs an operation, reducing them to 2 numbers. A pair of values is calculated for each tile and registered in respective heat maps. This concludes the first network. A classification network is then applied to this array of tile representations. The respective pair of values for each tile are compared to a probability space, and the mean value is calculated. This reduces to a single point, yielding the probability for poor prognosis. This prediction of the probability of poor prognosis is the final representation for the first model. For each resolution, there is an ensemble of 5 trained models, created by 5 unique training runs. Due to random initialization and sampling, each trained network is unique. When applied, they produce 5 different predictions of poor prognosis. The 5 40x predictions are averaged, and the result is a new predicted probability of poor prognosis, which is termed the 40x ensemble model prediction. To calculate the ensemble prediction for 10x, we retile the delineated area at 10x magnification and repeat the process with 5 different models. This is the final ensemble prediction for 10x resolution. A threshold value determined by evaluation during training is used as an ensemble marker to predict either good or poor prognosis. We compare the probability predictions of both resolutions to the respective ensemble marker. The combination, termed the Tumor V1 CRC marker, predicted good prognosis if both ensemble markers predicted good prognosis, uncertain prognosis if the ensemble markers predicted differently, and poor prognosis if both ensemble markers predicted poor prognosis. To evaluate the Tumor V1 CRC marker, we first analysed a test cohort consisting of 920 patients from the Gloucester Colorectal Cancer Study, UK. Their slides were prepared in a different laboratory and from different tumour tissue blocks than those used in the training and tuning cohorts. The marker separated the patients into 3 risk groups with clearly different cancer-specific survival. Patients in the poor prognosis group had more than 4 times higher hazard of cancer-specific death than patients in the good prognosis group. The Tumor V1 CRC classifier was also a significant predictor of cancer-specific survival in Stage 2 and Stage 3. This strong prognostic performance indicates its applicability in different laboratories. We then independently validated the marker in a cohort of patients from 170 hospitals in 7 countries, recruited to the Quasar-2 trial. These patients had Stage 3 or high-risk Stage 2 colorectal cancer. Slides from 1,122 patients were prepared in Oslo and scanned using the 2 scanners, resulting in 2,234 whole slide images. The analyses were pre-specified in a protocol prior to all investigations that could reveal associations between the slides and cancer-specific survival. The classifier provided additional information on the risk of cancer-specific death. After adjusting for established prognostic markers, patients in the poor prognosis group of the Tumor V1 CRC marker still had about 3 times higher hazard of cancer-specific death than those in the good prognosis group. A similarly accurate separation of patients into risk groups was observed when analysing the marker in all patients. PN stage describes the tumour spread to lymph nodes and is known to be important for patient prognosis. PN2 identifies patients with at least 4 lymph node metastases and is a strong predictor of poor outcome. The Tumor V1 CRC marker identified patient groups with substantially different cancer-specific survival within both stage PN1 and PN2. The marker may be used to identify the few low-risk stage 2 patients who need adjuvant chemotherapy and thereby spare the other low-risk stage 2 patients for unnecessary toxicity and its associated side effects. It also appears to identify many Stage 3 patients with sufficiently low risk to warrant a discussion of the limited survival benefit of chemotherapy compared to the complications associated with the treatment. The Tumor V1 CRC marker may also refine the risk stratification of patients who should be offered adjuvant chemotherapy, which could be used to guide treatment choices. Patients at high risk of cancer death may be offered the more aggressive combination therapies, while other patients may prefer a less aggressive single-agent chemotherapy. As the Tumor V1 CRC marker analyze slides that are prepared as a part of the routine histopathological examinations, it is technically simple to apply and may be offered as a service anywhere. It provides much additional information about the patient outcome, which could enable more appropriate selection of adjuvant treatment after colorectal cancer resection. For more information, please read our publication in the Lancet.